Hello everybody, my name's Louise Fay. I'm a specialist O&G at the Royal Hospital for Women. This webinar tonight is on behalf of the staff of the Royal Hospital for Women and in collaboration with our GP Shared Care partners and the PHN. This presentation was prepared with the assistance of Dr. Siobhan Lee, and the midwives at the Royal Hospital for Women, who are major stakeholders in GP Shared Care, Dr. Andrew Bissets, Dr. Antonia Shand, and our GP Shared Care representatives, Dr. Krista McGough, Dr. Jill McDonnell, and Dr. Galina Pachewska. In addition, we had the assistance of Dr. Steve Coogan, Dr. Wendy Hawke, and Dr. Stephen Horowitz. So far in New South Wales, we have had 12 confirmed COVID cases in pregnant women as of the 16th of April 2020. Fortunately, we've had no major maternal morbidity and no neonatal morbidity. There's been no known vertical transmission cases. So the background, I'm sure, as we know so far, COVID does not appear to be worse in pregnancy, unlike conditions such as influenza. Obviously, in the setting of severe maternal illness, this is likely to escalate. There is some evidence evolving, especially from data from countries who have had significant numbers of COVID, such as the UK and the US, that there is possibly vertical transmission in utero, and third trimester complications which are reflective of maternal disease, which will be worse in the third trimester, of fetal growth restriction, fetal distress in labour, and in utero fetal death. So at the Royal Hospital for Women, obviously our aim is to reduce patient-to-patient transmission, healthcare worker transmission, and possible any elderly people that may also attend the Royal Hospital for Women for services such as gynaecology. So first of all, I'm just going to take you through the routine clinics in obstetrics. I would like to emphasize it is business as usual in the maternity setting. Obviously, it's very different from the government cessation of elective surgical cases. We cannot stop babies coming, which is good, and we're trying to make the environment as safe and as healthy as possible for everybody involved. So I'm going to take you through the antenatal clinic schedule first, because obviously in GP Shared Care, that's where the most would be most pertinent for your practices. So I'm just going to show you, you will have received this so far already, where the antenatal schedule of visits during the COVID pandemic has been revised somewhat, and we have just kept, for convenience sake, for the primip and multips to have the same schedules, apart from a couple in the third trimester. So from the 6 to 12 weeks, obviously, to confirm pregnancy, to confirm ongoing viability, as usual, that is with GPs. That's just normal protocol with screening bloods, giving first trimester screening, the routine antenatal bloods, scans for morphology down the line. Obviously, at this point in time, the flu vaccine is very important, and to triage people for early diabetes screening. We would encourage women to book online at the Royal Hospital for Women, and also there is the number there to fax the referral. Obviously, we want to see women with pre-existing medical conditions that may require early obstetric intervention with the high-risk clinic or obstetric hematology or with obstetric medicine. So obviously hypertension, pre-existing renal or liver disease, and previous significant obstetric outcomes such as severe IUGR and significant preeclampsia before 34 weeks, and or any stillbirth or neonatal deaths. So obviously this is what you would be familiar and used to, but we would just like to emphasize that if you do need any urgent referrals, please let us know. Between 14 and 16 weeks, which would traditionally be the midwife visit in person, we have now transferred this over to telehealth unless the patient needs to be seen. This is an hour-long hospital booking over telehealth. Obviously, we will have the patient's results and first trimester screening by then, and we'll do a psychosocial screening and review the results and triage whether they need to be seen in a specialist obstetric or maternal fetal medicine clinic at that point. At 20 to 21 weeks, the patient will go back to see yourselves in clinic. Obviously, telehealth may be more appropriate for some women. The morphology scan will be reviewed at this point. Boostrix can be given from 20 weeks onwards, especially to consider in women who have a history of preterm birth. Flu vaccine given if not already given, and then provide the patients with the routine 26 to 28 screening blood tests for antibody screens and for a full blood count. At this point, obviously, if there is any problems with the morphology scan or you're concerned, please don't hesitate to call the GP triage line, any obstetric consultants or registrars through Switch. We are encouraging to make sure that all of you receive the handwritten GP shared care antenatal visit either through telehealth or by fax from any of our encounters with your patients. At 22 weeks, the patient must be seen for a face-to-face, and this is for a DV screening check. Also, we can take this opportunity as well if the patient hasn't had their Boostrix, their flu vaccine, and if they need any further ongoing psychological input from our specialist perinatal mental health team. At 26 to 27 weeks, obviously the patients are going to have their routine screening tests. We do have an additional handout that's already been sent to you about altered screening according to ADIPS guidelines for gestational diabetes, and we'll go through that. The 28-week visit will take place with yourselves face-to-face. We would encourage all women to be seen face-to-face from this point onwards, obviously for screening for blood pressure issues and or growth restriction or small for gestational age. Obviously, giving the patients paper copies of results is preferable. We obviously can't endorse giving them snapshots by their iPhone, but that's clearly the most handiest way to do things. And once again, just to emphasize the Boostrix and flu vaccine. Following this, the patient will have a face-to-face visit at the Royal, either with a midwife or by the medical team of the GP shared care clinic. They will get their anti-D at this point at 31 weeks instead of 28. And we will discuss routine third trimester issues such as fetal movements, when to call, give them the information for the triage line, and to discuss what the postnatal plan will be. At 34 weeks, we have placed a optional visit with their general practitioner if they're multiparous women. We would encourage all nulliparous women to go to this visit, as this may give an opportunity to pick up some early signs of a gestational hypertension, small for gestational age, or even preeclampsia. At 36 weeks, there's a Royal Hospital for Women face-to-face meeting. Anti-D is given at this visit again. They can have their low vaginal swab taken for Group B strep. We will repeat the full blood count if there are risk factors for anemia. There's no need to repeat it if women have got healthy iron stores, they haven't been affected, asymptomatic, and are currently on iron supplements also. At this visit, we have instituted a bedside scan for all women to confirm cephalic presentation. This is obviously to avoid any undiagnosed breaches in labour, which is traditionally what we do encounter from time to time, but we've instituted this in an effort to reduce this incidence, and especially if women are going to be attending less. If a woman does need a caesarean section for whatever reason, such as a low-lying placenta, an elective repeat caesarean section, we are going to do this and give them their paperwork and possibly a date for a caesarean section where applicable. I'll go through the NBAC clinic and the pre-admission clinic in the further schedule of visits. At 38 weeks, we'd like all women to be seen by their GP to discuss postnatal supports and strategies for ongoing postnatal care in the community. At 39 weeks, we would like to see women having their first baby. and offer them a sweep and talk about the possibility of going over their due date and what induction involves. We don't feel the need for multiparous women to attend at 39 weeks if they don't wish to, and are happy for them to be seen then at term. The 40-week visit is a face-to-face visit again, where we will offer a vaginal examination and a sweep where applicable, and if women want to do so, and then we will book an induction for the routine term +7 to term +10, and any ongoing care for those who don't wish for this. Postnatally then, there is a telehealth item number recently instituted between 1 and 4 weeks, and then from a 6-week visit to see their GP face-to-face for a mother and baby visit. Obviously, we're happy to see any women who've had any complex deliveries or need to be seen sooner in the postnatal setting at the Royal Hospital for Women. Just to note, the appointments are currently approximately 15 minutes face-to-face. We are trying to keep everybody very aware of socially distancing. We don't encourage partners to attend unless absolutely necessary. Our interpreter services, which are very important to us, are all done by phone now, which sometimes can be a little bit difficult, but we do try to make it work. We do have a cross-cultural worker, Galoo, who's very good at seeing all of our patients, and she works approximately 3 days a week at the Royal. Mental health in this current climate, which would be obviously very much part of your practice, is probably going to be more of the GP setting. The antenatal and perinatal mental health group is obviously still working and seeing women face-to-face where appropriate. So if you've got any questions about that, please do not hesitate to contact us. So just going back then to the rest of the other clinics that we have at the Royal. So just to go through the anti-D, as I said, we're giving anti-D at 31 and 36 weeks, which are both face-to-face visits at the Royal. Influenza, any opportunity, obviously from booking onwards. This is available at the Royal as well, but I would assume the majority of influenza vaccination will come from general practice. Pertussis from 20 to 32 weeks, obviously given it in each pregnancy. Partners have a 5-year. And please remember to consider women who are at risk of preterm birth, given it earlier. In the NBAC clinic for women who are considering delivery after 1 previous or 2 previous cesarean sections. This is done via telehealth at 24 weeks, and women are quite happy to be involved in a collective conference for a group information session and then seen either via telehealth or a phone consult 1-to-1. And the reason why we choose it at 24 weeks is that a lot of women will be coming in to see us at 31 weeks, or to discuss it with yourselves at 28 weeks. The breech clinic obviously is still being provided by professor visits. If a woman is breech at 36 or 37 weeks as confirmed on scan, they don't need to see professor visits at that point, because every obstetrician will offer the woman a external cephalic version where seen fit, and that's booked directly with the delivery suite, and the woman has a ultrasound scan either during that week that she's found to be breech, but it's definitely done prior to her ultrasound scan. If the woman maintains to be in a breech position, she does see professor visits to be further counselled about the option of having a vaginal breech delivery. The endocrine clinic, which is obviously a huge service for thyroid disease, for diabetes, for pre-existing diabetes, type 1 and type 2, and for non-insulin dependent diabetes, is still continuing on. Obviously, some appointments are appropriate via telehealth, and other women need to be seen face-to-face by both obstetricians and endocrinologists. The obstetric medicine, the high-risk clinic, and the obstetric haematology clinic, which is a combined clinic on a Thursday afternoon, is obviously still proceeding. Some women may wish to be seen via telehealth, and this may be very appropriate, such as women with chronic hypertension, very stable, and who are emailing their blood pressures. Other high-risk patients may need to be seen as appropriate, and obviously any new referrals. In maternal fetal medicine, Antonia Shand was very emphatic today to let you all know that it is business as usual. High risk, no schedules have changed there. High risk first trimester screening, obviously call the fetus phone, provide the ultrasound scan and the referral, and call the fetus phone midwives on 04375 37448. Genetic counselling is obviously as per routine recommendations, and that is usually provided via telehealth at this point. Fetal cardiac echoes are all triaged by maternal fetal medicine. The perinatal loss clinic is currently via telehealth, and the twins clinic, which is on a Wednesday afternoon, is as per normal schedule. All visits are by referral, and you have got very helpful MFM midwives, Kate and Judith, who will answer your calls Monday to Friday between 9 a.m. and 5 p.m. Any urgent referrals outside of these hours, of course, feel free to call the delivery suite registrar, where there is a presence 24 hours a day. In the diabetes screening, which I will just go through on a separate page, obviously the reason why it's changed a little bit is because the length of the GTT, and obviously not allowing women to sit in laboratories for over 2 to 3 hours where they would be at risk of getting coronavirus. We don't provide this service at Seals, and some people obviously who do need a 2-hour GTT, they're probably best directed by yourselves, where there would be quite large laboratories with rooms for pregnant women who need diabetes screening. So the clinics obviously are still running as normal. The clinic on a Monday afternoon is Professor Bissett's and Professor Lowe. The clinic on a Wednesday morning is Wendy Hawke and Dr. Sue Lau and Dr. Amanda Beach. Diabetes educator Justine is obviously still present and doing a lot via telehealth presently, which the new ADIPS guideline, we have for women with pre-existing diabetes and women who are high risk, as you can see from the document there, and this document is going to be sent out to you. We would like women to have a HbA1c and provide GDM management according to the results. So no GTT in the first trimester. For women who've not been diagnosed with GDM in a previous pregnancy, they can have their glucose tolerance test as standard care in the 3rd trimester. They will have a fasting blood glucose, and if it's 4.6 millimoles or less, they do not require a GTT. If it's 5.1 millimoles or greater, the fasting, they need GDM management. And if it's in between, we are going to perform a GTT. For women who have been diagnosed with GDM in a previous pregnancy and with a normal HbA1c in the 1st trimester, they are going to have an oral glucose tolerance test at 24 to 28 weeks as standard care, and triaged with their fasting blood glucose as above. In the 2nd page of this document, we have an algorithm from Queensland Health, which is very helpful, and we have provided this to you in a separate attachment. So that's the newly formatted diabetes screening. Obviously, if you feel that somebody needs a GTT, if they're very borderline, and there is a place for them in a laboratory locally to have a glucose tolerance test, then that is an acceptable way of screening still. Next slide is about perinatal mental health. The perinatal mental health CNC, Robbie, and the medical team are triaging via phone calls and telehealth. Obviously, this can be a large part of the antenatal service. In terms of postnatal mental health, which is obviously very, very important, the service is limited geographically according to the patient's catchment. Obviously, the 1-800 number for acute or high-risk patients is still being attended to as per normal. And Robbie, our CNC on that mobile number there, can assist with triaging. Our perinatal perinatal mental health psychiatrist, psychiatry team are still on site. They're still seeing patients, and they're also seeing patients via telehealth and phone consults. In terms of antenatal education, obviously the group gatherings are gone. For bookings, there are we are hopeful to have live stream events in the next few months. I know that hypnobirthing and cam birthing are live streaming, and then there's good online resources for antenatal care through our college website, that's ranscog.edu.au, and through the RCOG. Moving on then to gynaecology, the routine clinics in gynaecology are all being triaged. Most clinics now are on a very minimal service for routine care. All post-operative follow-ups are being triaged over the phone. Obviously, if somebody's got a significant wound infection or a complication post-operatively, they will need to be seen through the emergency room at Prince of Wales. We would also like to emphasise that women who need to be urgently seen, that you may have seen in your rooms or in your surgeries that day, such as a query ovarian torsion, as an ectopic pregnancy, they should be seen without any undue delay, and it's very reasonable to call the gynaecology registrar through switch 24 hours, and the patient may need even to attend resus in Prince of Wales emergency. So the only clinic that's closed for service at the moment is the bone density clinic, but every other clinic effectively is open, but it is by telehealth, obviously not the procedure clinic unless it's urgent. For colposcopy services, high risk are all seen as per guidelines. It's business as usual there, there's no changes, and any low risk patients who can be seen in a couple of months' time, or who may just need a repeat colposcopy or a HPV screening with a liquid-based cytology can be triaged and can be reassured over the phone and given a follow-up appointment for a few months' time. Obviously, all face-to-face consults which are deemed necessary will be booked in accordingly. In the fertility department, at the moment, we're not offering any first visits unless those patients who need any urgent fertility preservation. Obviously, the majority of these cases would come through the oncology services in the area district. We are still seeing patients through the fertility clinic for this reason, and we are performing urgent fertility preservation cycles. Other services such as ovulation induction, intrauterine insemination, routine andrology, routine endocrine reproductive endocrinology tests are not being performed. And we are informing patients that we are keeping a kind of a live log of patients who will be requiring treatment soon, and we'll get in touch with them once our services are up and running again. As said before, acute gynaecology that need to be seen through the emergency room or you'd like to discuss over the phone, please call. Professor Jason Abbott is triaging everybody who's on the surgical wait list. We do have an emergency gynae list theatre going every day where we are categorising the category 1 cases, such as women with postmenopausal bleeding, which would be the commonest case. Obviously, gynae-oncology are still running their services as per normal. And then I will just take you through the early pregnancy clinic, as there's been a few changes there. So as you're aware, the EPAS clinic is by appointment only. However, we have extended the hours. Weekdays now, it's between 8 o'clock and 4 o'clock, and Saturdays between 9 AM and 2 PM. We would like all bloods and scans faxed to that number there, 9382 6638, and any further information that you may like to add for the patient's appointment. We cannot allow partners, and I know it's a difficult time when people are being diagnosed with miscarriage, for face-to-face consults, as there isn't enough room in the department. We will follow women up with face-to-face or telehealth consults as necessary. A gynaecology consultant is overseeing EPAS every day to make sure it runs hyper efficiently during this time, and that are seen appropriately and are followed up appropriately and offered appropriate treatment. Obviously, there will be still cases where there will be miscarriages, incomplete miscarriages, pregnancies of unknown location, and possible ectopic pregnancies that will need to be seen through Prince of Wales Emergency Room. We'd emphasise, please, to send them in. There is a Gynae on Call service 24 hours a day, and please call the Gynae on Call registrar, and that pager is held by the night registrar, who is there every night for 12 hours. There is a dedicated room for women with respiratory symptoms who are deemed suspicious for coronavirus or may have already been diagnosed with coronavirus. So we'd like to let you know that if they do need to be seen in an emergency, there is provisions available for them. There is a separate ultrasound machine, and we can organise blood tests for them. For women who are having booked caesarean sections, their paperwork is forwarded from their 36-week visit, some women even at the 31-week visit. For all of their pre-admission clinic, which was formerly on a Friday morning in the antenatal outpatients with an anaesthetic review, this is by telehealth only. There's no face-to-face consult. Obviously, every woman who comes on the morning of her caesarean section will be coming in approximately 2 hours beforehand and will have an anaesthetic review accordingly. There is a consultant anaesthetist and an anaesthetic registrar assigned to each visit, and our caesarean section lists are running Monday to Friday as normal, and emergencies during the day as normal from the labour ward. The patient does collect their pact for the caesarean section the week before, where obviously they will be seen for a routine antenatal visit and have their blood forms, their fasting times, and their Chlorhex solution for cleaning in that pack that they would have previously gotten at the pre-admission clinic. From caesarean sections to pregnancy day stay, as you're aware, we have a pregnancy day stay unit where we see women with chronic pregnancy conditions that don't need inpatient management but aren't suitable for routine antenatal visits. That number there, the top left-hand corner, is direct to the pregnancy day stay unit. Usually referrals do come from either the antenatal clinic or maternal fetal medicine, but obviously if you wish to book a patient in or speak to one of the midwives or the registrars who are in that clinic every day, please do not hesitate to call. It just optimises the flow of care, the continuity of care, and for patients who already have been in hospital possibly for a while, say with premature pre-labour rupture of membranes, with chronic hypertension that need further evaluation, that may be developing mild preeclampsia, women with small for gestational age, babies. Where you might see it handy as a service for your patients would be women with quite intractable hyperemesis who do need admission for a short period of time to have IV fluids and some IV antiemetics. More acute antenatal problems over 20 weeks need to be assessed in delivery suite, and that triage phone number hasn't changed. That's on their yellow card. That is the dedicated triage midwife. Her number is there and it's a direct line. So that will be for things that you may see in your clinic, such as urgent hypertension, reduced fetal movements, spontaneous rupture of membranes prior to term, antepartum hemorrhage, concerns regarding PV discharge, pain, or a woman who's been in a motor vehicle accident and needs to be assessed over a long period of time. Obviously, anything else that you're worried about, please do not hesitate to call via switch, where there is a consultant, a midwife, a registrar, a junior registrar available every day, 24 hours a day. So obviously frequently asked questions in labour and delivery, because not many of you might have been in a hospital environment for a while, but as you can imagine, coronavirus has changed the landscape. All the chairs are taken away, there's no hanging around in lobbies, there's huge big posters, everyone has to queue up at the Prince of Wales delivery to be screened, and the same for Prince of Wales Private. So very frequently asked questions that will obviously give some anxiety to patients is about their partners being allowed in. And yes, of course, partners are allowed in, or a support person, but screening does take place at the main entrance between Prince of Wales and the Royal. And obviously, if a partner has got respiratory symptoms or any symptoms suspicious of coronavirus, they will not get past the door. So we do tell women, please have a contingency plan, because it is upsetting for them if they do come to the door and the partner can't come in. Obviously, all labouring women will be allowed in regardless of their status. We have sent out a very comprehensive coronavirus algorithm of care that Dr. Amanda Beach has formulated in association with infectious diseases and our intensivists, where there is a hospital protocol for women if the patient is suspected or confirmed COVID positive. So we're not talking about an acute setting where a woman has got a severe respiratory compromise. This is just about women who possibly may have coronavirus, might have been in touch with coronavirus, or might be high risk for it. So women in labour, women who are being induced and postnatally, obviously it's business as usual. A lot of our antenatal education is telling women about when's the time to call, when membranes rupture at term, if fetal movements change, when labour is happening. Obviously, the antenatal classes and education has been taken away from this as part of their antenatal education, and hopefully we'll have this up and running via telehealth soon. We only can have one support person in the room, and that support person has to be the same person with them all of the time. We can't have people swapping in and out, which obviously is understandable. There's no additional visitors allowed. Unfortunately, women with children, their children cannot come to the hospital and see their new sibling or their mum having a baby. We don't allow any deliveries to the hospital. We don't allow flowers. We don't allow Uber Eats. We don't allow anything like that. The cafes are still operational in the hospital, and partners may go down there and get any refreshments or snacks for their partners. The aim is to reduce the postnatal stay, which I will go through, and the domiciliary midwifery visits are as per normal schedule. So if there is, just briefly to touch on, if there is a suspected or confirmed case of coronavirus in labour, unfortunately the woman has to labour by herself. Her partner cannot be there with her, which is can be quite worrying for especially the prima who may need induction. Obviously there is ongoing one-to-one midwifery care, and the midwife will be with her at all times because the midwife does not leave the room. The COVID positive mothers must wear a mask, and they're not able to leave the room unless there is a reason for them by the midwife in charge, such as going to the radiology department for a specialist scan or something like that. They are encouraged to have an early epidural, so we're not faced with an emergency cesarean section requiring a general anaesthetic, which puts a major risk to the woman and to all healthcare workers around her. We spend a lot of time doing skills and drills about donning and doffing PPE in this scenario in theatre. I can tell you it takes many, many steps, and hopefully we won't have to do it too often. And COVID positive mothers can obviously breastfeed, but it is advised that they wear a mask while they are breastfeeding, and then when the baby is sleeping in their cot, that it's not beside the bed, that it's a minimum of 1.5 metres, so that the baby is social distancing from its mum. In the nursery at present, obviously with a heightened infection control around all preterm babies, only one parent can be with their baby at any one time, which I know is distressing for parents, especially when the neonatologists are doing their ward rounds and talking to the mothers and fathers about the progress of their babies. But this is obviously to reduce throughput through the special care nursery and NICU in order to reduce any increased chance of coronavirus in preemie babies, which may significantly compromise their health and well-being. So for the postnatal services, we are offering reduced postnatal stay, which obviously can be very attractive to women, especially if they've got young children at home. So obviously the midwifery group practices and the domiciliary programs can offer straight home on the same day, but we would encourage women to have a 24-hour discharge post-vaginal birth and 48 hours post-caesarean section. Obviously, depending on the clinical scenario, where you're not going to discharge anyone where they are not fit to be discharged. And there is a dedicated postnatal medical and midwifery team who will obviously review everybody's individual scenario each morning. The midwifery programme at the home will perform between 2 and 3 visits, depending on clinical needs. Any postnatal emergencies, such as a secondary PPH, sepsis, we do encourage them to call that triage midwife in delivery suite with the mobile number. We would not like to think of anybody at home septic and thinking that they're going to be considered that they've got coronavirus. Obviously, there's mastitis to consider, endometritis, group A sepsis, very significant morbidity postnatally that does need inpatient hospital admission. There is a telehealth item number for all patients 2 to 4 weeks postpartum, and we would encourage GPs to set this up for all of their patients. I think even for perinatal mental health, if anything else, especially for primates and people who can't have any parental involvement and feel very socially isolated. The Child and Family Health Services, I've got a special slide from Nora Crotty because she wanted to liaise with all GPs to make sure that everyone was clear about the district or the area Child and Health Services, and our Oasis clinic for any kind of significant perineal trauma during labour and delivery. They still will be offered an appointment and they will be reviewed face-to-face where deemed appropriate, and for physio services as well. So the Child and Family Health update by the clinical nurse specialist Nora Crotty was sent to us, that it's changed because home visiting is now suspended and all clinic visits are by appointment only. And there's a number there for core visits for breastfeeding support. Obviously the new parents group, which is a big part of women for their social gathering after having a baby in their local areas, has been suspended for the moment. They are looking at doing telehealth and Zoom meetings, however, this hasn't been set up yet. I've been advised that the best way to get updates on the Child and Family Health in the local area district is by Facebook. So this brings an end to the presentation from our end. I hope you found it helpful. This webinar is going live next week. Hopefully the numbers will remain stable and there won't be any new cases. There were 6 new cases diagnosed in New South Wales in the last 24 hours, and hopefully we will see stability in that and not much morbidity as seen elsewhere in the world. As I said before, we'd like to emphasise it is business as usual at the Royal Hospital for Women, despite having altered routine obstetric and gynecological visits. If you have any concerns about any of your patients, we would like to hear from you through any of those numbers. And I wish you a safe times during these unprecedented and difficult times to you all. Thank you.